question. I'm Dr. Paula Woodward, and I'm going to talk to you today about ultrasound. And we're going to get into some of the specifics. So here are our learning objectives for today. Really what I want you to come away with is just some general understandings of the principles of ultrasound. I want you to learn some basic terminology. And then what we're going to do is hopefully emphasize where ultrasound can really help and where it's limited. But before we talk about ultrasound specifically, I'm going to go back in time to the start of radiology, and then we're going to talk about how ultrasound fits into this. So when we go back, here's the guy. Here is the guy. This is Wilhelm Conrad Roentgen. He was born in Germany in 1845, went to the University of Zurich. And he, like all good scientists at that time, had a lab where he had this thing called a Crookes tube. Now, this was a vacuum tube, and this was the thing back in the late 1800s. Just like in the middle 20th century, scientists work with transistors, and now the microchip. But back then, it was the Crookes vacuum tube. And so here was his lab. So he had an electrical coil right here. He had the Crookes tube here. And over there, he had essentially what was a piece of film. All right. Well, what people didn't know at the time is when you put an electric current through this Crookes tube, it gave off this magical invisible ray, which we now know as the X-ray. So like all good scientific discoveries, this was made completely by accident because he went over to that other side of the lab and sitting on that piece of film, he had a series of scientific weights here. And he looked at that piece of film and lo and behold, he had this kind of shadowy photograph. So he thought this was really something pretty interesting. And so he shut himself up in the lab and started working on this. And he had no idea what this was. And so he just called it X because for the algebraic unknown, and that's where we get the name X-ray. So at the end of 7 weeks, he writes a paper on December 28th, 1895 on a new kind of ray. And he shows this image. And this is a really famous image in radiology. You can see it's a hand and here's a ring. And that's actually of his wife, Anna. Now, this was great for Wilhelm because he goes on to get the Nobel Prize a mere 6 years later. Not so great for Anna. Anna sees this as a vision portending her death. And she really kind of freaks out about all of this and goes into seclusion. So good for him, not so good for her. No other scientific advancement has hit as big on the public scale ever as X-rays did. Not only in the medical community, but in the populace. So here's one of the first X-ray labs. This was in Philadelphia. This was circa about 1900. You can see this is the generator right here. This little thing is actually where the X-rays are coming out of. And by the way, they're flying all around this room. They're going everywhere. One of the places that they're going is actually through the guy here. And then the doc is standing there. And he is using what's called a fluoroscope to focus those X-rays and look through this man. Well, as I said, not only was this a medical advance, but this hit the general public. X-ray studios opened in the streets of New York City. All the fashionable people went in and got their pictures taken at an X-ray studio. You could go to a shoe store and make sure your shoes fit by using X-rays. You could buy them from the Sears catalog. Here are a couple catalogs that had sell X-ray equipment to anybody who could afford it. And parties, you would rent these machines for parties in the fashionable districts. Here is a actually model, and she's standing in front of this X-ray. Right here, the doc is looking again through this fluoroscope. And again, notice that there is no protection anywhere. And we're going to get back to this fluoroscope in a minute. Well, as medicine started to advance, we got some pretty fancy x-ray machines in the hospital. I really wish we still had this one. It looks like a lot of fun. I'd like to do that. It hit Hollywood. There were x-ray pinup girls. And by the way, if your bones look like this, you have a serious problem. They used it for publicity stunts. So this was a movie from the 1930s where the lead actress, Judith Allen, went on a publicity tour taking x-rays of her lovely, nice straight spine and giving this very coquettish smile as she did that. All right, now back to that fluoroscope. So remember, the patient stood between the x-ray machine beam and this fluoroscope. Well, it took a while for the x-rays to warm up. So when did the doctor know when it was a good time to start looking at the patient? Well, they would hold their hand up and make sure they could see the bones in their hand until their hands started to look like this. And then people discovered at this point that x-rays, as well as being an extraordinary medical benefit, also were a serious hazard. And then they started to come up with early protective suits. I'm not sure I would want my doc coming in wearing one of these. This guy looks like a welder. To me, they both look more like minions than anything else. All right, so x-rays were great, but they were limited. And so if we want to see vessels, if we want to see internal organs, they had to think of some other things to do. So this is one of the first angiograms ever done, and this was an injection of mercury. And then they started injecting and having people swallow all kinds of things. One of them was thorium, which we know is radioactive. One was barium, which actually turned out to be pretty helpful, because what they would do is they would have a patient swallow the barium and then draw on the patient. You can see where they've outlined the lung here. Draw on the patient where their organs were. Well, then in the early 1900s, somebody else made a great discovery, and that's about iodine, which, by the way, we still use today for CT scans. Well, at the time, one of the big departments at the Mayo Clinic was the Department of Dermatology and Syphilology. Doubt it's there now, but it was big in the early 1900s. And one of the ways that syphilis was treated was with high doses of iodine. And they got this newfangled x-ray machine, and they noticed they could see the kidneys of the patients that were being treated with the iodine treatments. And so they figured out from there that that would be helpful if they want to look at kidneys and blood vessels. And like I say, we still use it today. So this was all great, but again, this is radiation. It's limited in what they can see. So our next big advance, and the hero of our story today, is ultrasound. Now, ultrasound developed directly from uses in World War II. And that's when sonar, which stands for sound navigation and ranging, was used from ships to map seafloors and, most importantly, look for submarines. Well, out of this came the idea that we could do a similar thing in a medical application. So it started in the 50s, and then this is one of the early ultrasounds where they actually had to completely submerge the patient. You see he has this head support here because he's being held down under the water, so the ultrasound beam can go through the water and bounce off of his organs. Well, that's in the 50s. In Life magazine in 1954, they had a feature, they had a whole medical section, and it was sound wave portrait in the flesh. And this guy is sitting in a bathtub. He does not look very happy. Sitting in a bathtub with some sort of plate here, so he has to be submerged in the water. And then this is the ultrasound technology. So they worked on getting this water bath easier to use. Here is a pan scanner where you actually set in a pan and then this thing went around you. This is one of the first images from this. I'm going to guess that's that guy's liver, but I don't know that for sure. But by 1965, we're back in Life magazine again because it's one of the first images of a fetus, a sonar look at an unborn baby. Now, check out the contraption here. No longer are you sitting in the water bath, but this is the water bath is coming to you. So this is all water, and then it drapes across the area that you're seeing, and then the ultrasound transducer is right in here. Well, nowadays, it's much different, isn't it? First of all, there is no water bath. We use a coupling gel to scan. This is a, quote, big machine, and we even have some handheld devices now, too. So we've come an awfully long way. This is one of the first published ultrasound, diagnostic ultrasounds, and you can decide what you think this is. To me, it looks kind of like a giant eyeball. Here's some eyelashes out here, but you can decide what you think it is, and the answer is it's a 14-week gestation. Apparently the fetus is over here, but read what down this last line. Provisional diagnosis had been made of that of a fibroid. So now we're able to diagnose a 14-week ultrasound instead of a fibroid. We have come a long way, baby. By the 1970s, technology has improved. I can tell this is a fetus. I can't tell you anything about it. I can't tell you if it's normal or not normal, but at least I can recognize it as a fetus. And now we can do extraordinary things. We can have 3D ultrasound. We have 4D, which is watching the 3D move. Here's a fetus sucking his thumb, and everybody out there is going, oh, that's so cute, and aren't we such an advanced species? But let me just show you a baby chick or a fetal chick doing exactly the same behavior. So it's really not that advanced. All right, so now let's talk more specifically about ultrasound. So audible ultrasound is in the range of 20 to 20,000 hertz. Medical ultrasound is about 100 times that. It's 2 to 15 megahertz. So it's a much, much higher frequency that we're dealing with. And it has some distinct advantages. The first of being no radiation. And it has a huge role in obstetrical imaging, in pediatric imaging, in gynecologic imaging, because it does not have any radiation. It's relatively inexpensive. I have that in quotation marks because it's still going to cost you tens of thousands or a couple $100,000 per machine. But it is smaller and portable as opposed to a CT or MR scanner. Now, there are two distinct types of ultrasounds. There's point of care ultrasound and there's diagnostic ultrasound. All of you out there, no matter what specialty you go into, will be involved with some point of care ultrasound. The point of these, it's a limited scan at the bedside to answer a specific question. Diagnostic ultrasound, on the other hand, is a detailed exam performed and interpreted in radiology. We have established protocols and a checklist. We use multiple transducers and scanning techniques. But let's start by looking at some point of care scans that you're going to encounter sometime in your medical career. The first being the FAST scan, which stands for Focused Assessment with Sonography for Trauma. And essentially here you're going to look at 4 different points of the body. So let's start right up here. And this is angled upwards, looking at the heart. You can see the 4 chambers of the heart here. This is the right ventricle, left ventricle, and this is a pericardial effusion. The next spot you're going to look at is one of the most important, and it's in the right pericolic gutter in the area of Morson's pouch. It's important because Morson's pouch is the most dependent portion of the abdomen, and that's where you're going to see fluid accumulate. Here's clot. Here's some free fluid in the flank. Then you're going to look down at the pelvis, because that is the deepest point in the pelvis, looking at the bladder, and behind the bladder is the pouch of Douglas, and there's blood in the pouch of Douglas. And then finally up by the spleen. Now this is a harder area to see, but you can see some fluid around the spleen. So that's the FAST exam. Another place you might use point of care is you're working in the unit and a patient has abdominal distension. And so you can quickly see their belly is full of fluid. This is the uterus. This is fluid down in the pouch of Douglas. Or maybe you're doing a procedure like putting in a chest tube. So you want to find your spot and look for the biggest pocket of fluid and then put your chest tube in. So that's all point of care ultrasound. Now we're going to talk a little bit more about the specifics about how ultrasound is made and how we can make our image and how we can tweak our image to get the most diagnostic information. Now, first of all, the picture that you're getting is very much like that sonar that detected the submarine. It is sending out a beam, and as soon as it hits something, that beam comes back to you. And so the echoes are made by interfaces. And it really reflects the complexity of the structure and not the specific tissue type. So let me show you what I'm talking about. Is here we have some fat in the breast, okay? And here we have fat in a renal tumor called an angiomyolipoma, which by the way is a benign renal tumor. Well, this fat, the ultrasound beam comes in. Let's look at the histology. The ultrasound beam goes in. And this isn't a very complicated structure. So the beam goes right through and it looks relatively dark or hypoechoic to our eyes. On this one though, the ultrasound beam comes in here and it hits fat and it hits smooth muscle and it hits a vessel. And this is very complicated. So this beam is bouncing back and forth and back and forth and back and forth through here. And it makes something very echogenic. Okay? And so even though both of these are fat containing, they look completely different because this one is much more complex on the bottom. So what are some advantages of ultrasound? Well, ultrasound is awesome for telling cyst versus solid, and if it's complex or if it's simple at cyst. So let's look at that. And we're going to learn words. We're going to learn to use our medical imaging words. And the three ways we describe structures, they're either anechoic, meaning no echoes, hypoechoic, meaning low-level echoes, or they're echogenic. Also, we can use the word hyperechoic, and they appear bright, like that last case I showed you. Then we have two helpful artifacts. Now, we generally don't think of an artifact as being something helpful, but in ultrasound it is. We have shadowing, where the sound waves are blocked, and we have enhanced or increased through transmission, where the sound waves are increased. So let's see how that works. So we'll start with increased through transmission. So what happens, here's our ultrasound transducer, here's our beam. It hits a cyst, and the sound beam doesn't get attenuated, and it travels through, and the sound is amplified beyond it. Let's look at an actual example. And I'd pay attention to this example because I think you may see it again towards the end of this lecture. So here is our cyst, and we'll describe that as anechoic. There are no echoes within it, anechoic, and that means it's a cyst. And then this is enhanced or increased through transmission. See how that's very bright? Well, what's happening is the ultrasound beam is going through the liver here. And as it goes through the liver is bouncing back echoes. It's bouncing back echoes. And so it's working its way, it's working its way, it's working its way. All right, but it's being attenuated the whole time it's going deeper. Now here, it's going down, and then it hits this, and all of a sudden, it doesn't get attenuated anymore, and it goes flying through here, And when it goes flying through there, it has increased energy because it wasn't attenuated. And so this looks brighter than the exact same spot over here. And that's increased through transmission. So let's just look at another case. Here we have a cyst in the top of the kidney, and you can see how simple the wall looks there. And as I said, ultrasound is great for looking at simple versus complex. This one was very simple. This one's complex with all kinds of echoes and septations going through it. This happens to be a multilocular cystic nephroma. That's not important. What I want you to recognize is that this is a complex cystic mass on ultrasound. Here's another one. This happened to be a cystic renal cell carcinoma, but it's very easy to see the complex nature on ultrasound. And in many ways, ultrasound will do better than CT on this. Now here we have a giant dermoid. All right, so here's the CT. You can see we have a septation there, and we have some faint things right here. But let's look at that same thing on ultrasound, and wow, it's way more complex on ultrasound. There's that septation, but look at all these little echogenic floating balls in there. And you see these little dots and dashes. That's what hair looks like on ultrasound. You would never see hair on CT. And there's the dermoid after it comes out with big gooey pieces of fat. And then there's the hair going through there. All right, how about a solid mass? Well, the key to a solid mass is that there's no enhanced through transmission. And the mass we're going to describe using our words we learned, and they can either be hypo, iso, or hyperechoic compared to the surrounding structures. So here we have a renal mass that's a renal cell cancer, and it's relatively isoechoic to the kidney, all right? But it's very solid and there's no increase through transmission. Let's look at this one. This one is echogenic or hyperechoic compared to the surrounding kidney. And when you look at it, when it comes out, look how complicated it is. There's that fat part that I already showed you. Those are the vessels I already showed you, okay? So this is an angiomyolipoma. It is hyperechoic. All right, let's see how that compares to posterior acoustic shadowing. That's our other artifact that helps us. Well, this is kind of the opposite. Now the ultrasound beam comes down and it hits something that's really brightly reflective, and no ultrasound gets past it. That's super helpful for us when we're trying to diagnose something like gallstones. So here's the gallbladder, here's the gallstone, and this is posterior acoustic shadowing. This is another word that I think you should remember for later in the talk when we get to the quiz. So here's a patient with acute cholecystitis, and there's that gallstone. Almost all patients with acute cholecystitis have gallstones. We see the gallstone with shadowing. Then we start to look for other things, and what you see here is this is the gallbladder wall. It goes from here to here, and it's got edema in it. So I can diagnose acute cholecystitis. But I'm also showing you this to show you another artifact that we don't like, and it's a major limitation of ultrasound, is it cannot go through gas. So this is all bowel down here, and it just looks like a dirty smudge, okay? It creates this dirty shadow. And my point for you here is we never order ultrasound if you think that the abdominal pain your patient has may be from bowel, because ultrasound is not good for looking at bowel that has gas in it. Let me show you another example where we made a diagnosis because we saw gas, and that is, this is a kidney. They thought this patient had pyelonephritis. This is the bottom of the kidney, that's the top of the kidney. But see this bright echogenic area and this smudgy, dirty shadow? That was gas, but this, look how much easier gas is to see on CT. So it's important to know what is better on one imaging modality and what's better on another. And then this was emphysematous pyelonephritis, and you can see that's just a big old gooey kidney when they take it out. So organs matter. For gallbladder, looking for gallstones, ultrasound's way better than CT. Here are some obvious stones layering there, but look on CT, you don't even see them. And the reason is that a lot of gallstones are made from bilirubin, and they just mush right into the bile here, and you can't separate it from the bile. So for gallstones, ultrasound's way better, but here's a kidney stone, and a kidney stone, you're putting a bright object into an echogenic area, into this renal sinus fat. So CT is much better for looking for renal stones. Size matters, and when you look at this, you really want to avoid doing ultrasounds in really obese patients. So here's a kidney. In the thin guy, we can see corticomedullary differentiation. Look at the pyramids. They're so easy to see. There's the renal sinus fat. Look at the obese patient over here. This is the kidney down there. I can barely tell you there's a kidney there, let alone if there's anything wrong with it. All right? So think about that when you order scans on patients. Now, we do have specialized transducers that we can use to try to help us. The lower frequency transducers have deeper penetration but lower resolution. They're good for looking at the abdomen. Here's the pancreas right here. Higher frequency transducers have shallow penetration but better resolution. They're great for looking at something like the thyroid gland, which we're looking at right here. Now, we've been talking about really grayscale images to this point, but we can also look at Doppler flow. And Christian Doppler, he was a scientist in the 1800s. He made the observation that when an object is approaching you, it appears at a shorter wavelength than if it is moving away from you. And we've all experienced this with a siren, right? As a siren is coming towards you, it's a higher pitch. As it's going away from you, it's a lower pitch. Well, the moving object that we have within our bodies is actually blood flow. And so we can look at the wavelength that the blood flow is giving to the transducer. And don't worry, I'm not going to ask you the Doppler equation, but I bet you all learned it in physics class at one time or another. The point of this equation is the machine knows what all of these things are. It knows the frequency shift, the transducer, the angle, and the speed of sound in soft tissue, and it can solve for the velocity of the blood. And so here's a waveform that we typically get out, and we can see the velocity at systole, and we can see the velocity during diastole. We can also look with color Doppler. When blood is moving into this box, it is being given a red color. When it's moving out of this box, it's being given a blue color. So it has to do with the direction of flow. It doesn't have to do with something is an artery or a vein, which is kind of what's in our head when we think about blood vessels. And I can make this any color I want. I can make this same vessel now appear red just by flipping my scale. When I look at the scale, if you look at the black line, above the line is towards you, below the line is away from you. So the same vessel, here it's blue and here it's red. So the point being, it's arbitrarily assigned, and so don't think that means artery, vein, it doesn't. Okay, then we have something called Duplex Doppler, where we combine our color and we have our waveform right here. And so we can see both at the same time. And that's what we do in most circumstances. And where we use that a lot is to look for vascular stenoses, like in a carotid stenosis. So here we have normal flow. Here we have normal flow. We can see the whole vessel filling. When we get our waveform, our maximum systolic velocity is just under 150 centimeters per second. In the setting of a stenosis, a narrowing, we can see the narrowing right there, the velocity, both the systolic and diastolic, go way the heck up. It's sort of like a garden hose. If you let the water just come out of the garden hose, it comes out in a nice uniform pattern here and velocity. Then you put your thumb over it, and now it's coming out in a jet. And that's exactly what we're seeing here on our Doppler. We have special settings we can use to pick up slow flow. Here we have a guy who's coming in with acute right testicular pain. You see we have normal flow in the left testis, and the right testis, first of all, it looks big and kind of gnarly, and we don't have much flow in it. And that was torsion. And you can see here on the post-surgical specimen, there's the tight twist in the spermatocord. So we have all kinds of different types of settings we can use in this situation to help us. Okay, so we have a kidney ultrasound, and we have what looks like a pretty simple cyst, right? Let's use our words. So this is anechoic. We have enhanced through transmission. But when we put color Doppler on, what we see is, oh my goodness, that fills with flow, and this is actually a pseudoaneurysm, all right? So it's important that we put Doppler on. It's a really important adjunct to everything we do, and we use it essentially in every scan. All right, so we're going to do another differential that's very common in radiology, and that's a mass with low-level echoes. And a lot of masses can look a lot alike, just kind of like our characters here. And yes, both of these guys have soulful eyes, no question about it, but this one has a little bit more facial hair. Both of these guys has crazy eyes, but his forehead's a little longer. And that's what we do when we look at these. So we look for subtle differences between those. So our big differentials are, is it blood, is it mucin, or is it pus? Now, it's more nuanced than that for sure, but I just want to go over these big categories with you. And I'm going to talk about one of the more important things, and that's endometriosis. This is a real health problem in women for a source of pelvic pain. You will see it in almost any practice that you're involved with. We have three components: endometriosis. We have implants, which are these little things right here, and those cause adhesions. And you can see how this is the uterus. You can see how the peritoneum is just getting sucked into this implant right here. And here it is very severely. Well, one of the things that we look for are endometriomas, and they have these homogeneous low-level echoes. Sometimes they're described as ground glass. On path, they'll call them a chocolate cyst because the blood in there is so concentrated, it looks like chocolate. All right, so that is blood, and that's a endometrioma. But here's a hemorrhagic cyst, which is completely different because hemorrhagic cysts go away, but it has kind of a similar appearance, doesn't it? I know this is a hemorrhagic cyst because we followed it, and it did go away. See, that's just a little of a remnant of what's left. So now as a radiologist, as you start to learn more, you can look at some more subtle things. In this example, both ovaries are kind of stuck to each other. We call that kissing ovaries. They should never be by each other, and that suggests that they're adhesions. And then I can start looking for little subtle findings like these bright echogenic foci in the wall. That is seen in endometriomas and not in hemorrhagic cysts. Here's that same patient. There's the uterus. See the two ovaries with the endometriomas? They're sucked there. And then look at all the terrible adhesions that are all over the pelvis. I can use my transducer to perform a physical exam. So normally what you're going to see, this is the cervix. this is the uterus, this is bowel. And as I gently push on the cervix, you see bowel will slide easily over that. When I have an endometrioma here, when I push on the uterus in the same way, everything's stuck together. It's essentially a frozen pelvis. So now we're using our ultrasound as part of our physical examination. Okay, so what else is in our differential for low-level echoes? Well, mucin is another one. And this is an ovary, and mucinous tumors of the ovary are common. This is a mucinous cystadenoma. See, we're using our Doppler, and we can see there's flow in that septation. You can see it here being removed. Here's the uterus. That's the normal size uterus. And you can see the mucin coming out of it. Here's one that's malignant. This is a mucinous cyst adenocarcinoma. But look at the low-level echoes. This is mucin. But look, it's very complicated. It has multiple locules of varying echogenicity, of varying density on the CT. It has a big solid chunk right here. Solid chunks are always bad. And this is a mucinous cystadenocarcinoma. Here's the solid chunk. It looks very much like we're looking at on our ultrasound. And this is just a sea of mucin in the background. Okay, patient comes in for rule out hydronephrosis. We get that a lot. And we have two different patients. One is really sick and the other is not. And you can make your decision who you think looks sick and who you don't think looks sick. But what I want you to notice is that in this one, there are all kinds of low-level echoes inside. And that's actually pus. This is hydronephrosis. They do fine. This is pyonephrosis. That's an emergency because that has to be drained. Otherwise, they will become septic and can die from this. So that's important to recognize. So my point of all of this is that ultrasound is a sophisticated and nuanced procedure. I just gave you a little taste of what it is we can look at. But when we performed appropriately and interpreted by experts, it is an invaluable aid in patient care. All right, so that's the lecture portion. And now we're going to go through the quiz. All right, so I think Serena sent these the quiz questions out to you. And first we'll go over the questions and then I'll go over the answers with you. All right, so we're going to start by using your words, and I want you to use only nice words. Don't be like Michael here where I have to bleep you out. So use your correct words. And so here's your first two questions. This is a simple cyst. Use the correct terminology for describing these features that allows us to make the diagnosis. So how would you describe the echogenicity of this? And what is this artifact that we're seeing that tells us that this is a cyst? And by the way, I would have put color Doppler on when I did this to make sure there was no flow in this. That's always part of your exam. Okay. Now we're going to go on to the next question. What ultrasound feature is shown which helps make the diagnosis of a gallstone? So what do we call this artifact that tells us this is a brightly reflective stone? Your fourth question is, an area of vascular stenosis is diagnosed on Doppler ultrasound by the which of the following? Increased systolic velocity, decreased diastolic velocity, reversed flow, or orange uncolored Doppler. And then the last question is ultrasound is not the imaging modality of choice for which of the following people on your screen? Okay, we're going to go over the answers now. And hopefully this was pretty straightforward for you. So what are the correct terms? This is anechoic, okay? And it doesn't attenuate any echoes, so we have increased or enhanced, either one is fine, through transmission. So that tells us unequivocally this is a cyst. The next thing was our gallstone. And our gallstone is a bright reflector. It sends all the echoes back to the beam, and it doesn't allow any echoes to go through, and we call that posterior acoustic shadowing, okay, or shadowing was fine. Either of those are fine. An area of stenosis, vascular stenosis on Doppler ultrasound, what would it do? And it would absolutely increase systolic flow. And there is the area of narrowing. It also increases diastolic flow too, both. There's no reversal, and we already learned color doesn't mean anything. Color is just arbitrarily assigned by the person who's running the ultrasound. And then finally, who is not the imaging should be scanned with ultrasound? Well, it's perfect for pregnant women, children, small adults, but the answer is C. Ultrasound resolution is limited by the depth of penetration. We start to lose our ultrasound strength as we go down. All right, so that was just a little bit of an overview. I want to thank you for your attention. And I'm more than happy to answer any questions if anybody wants to send them through. I didn't do questions throughout because they were actually recording this for future classes, but I'm happy to answer any questions for you.
That was great. Thank you. Yeah, thank you very much.
I have a question.
You bet. You bet.
When you're looking at colored Doppler, I can understand if you're looking at a cross section of a vessel, if blood's going away or towards you. But when you're looking transverse, how do you tell which way the blood's coming towards the probe?
Really good question. You can't. You can't because you're transverse. If you're 90, we'll go back to the Doppler equation. If you're 90 degrees, the cosine of 90 is 0, you can't solve that equation. So you cannot tell. You have to flip the transducer and look in a longitudinal plane. That would have been a good test question.
Thank you.